Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. I'm Dr. Asma Kazi. I'm working as Associate Professor of Medicine at Rashid Latif Medical College. I have the privilege of working with Professor Azizur Rahman at the moment, one of the most passionate teachers and an excellent academician. I'm honored to be moderating this 8th session of a very comprehensive and extravagant course of hypertension arranged by the Pakistan Society of Internal Medicine. I welcome you all in it, and I hope and I'm sure it will further enhance everyone's knowledge on this very common and prevailing condition. First of all, I would like to invite our chairperson, Professor Mohammad Ishaq. Professor Mohammad Ishaq is a very renowned cardiologist practicing at Medicare Cardiac and General Hospital, Hyderabad, Karachi, and is a visiting consultant at Al Khan University Hospital. He did his MBBS from Khyber Medical College, Peshawar, MRCP from UK, FRCP from London, FSCC from USA, and FCPS also from Pakistan. He has 45 years of experience in this field. He's the Secretary General of Pakistan Hypertension League, Chair of ISH Regional Advisory Group, South and Central Asia, Chief Cardiology Examiner of CPSP, and also MRCP Examiner at Royal College of Physicians, UK. I humbly welcome you, sir, on this forum. Before going, I will just, I think everybody would be knowing the procedure, but just to let you know, we're going to have 2 sessions, 2 talks, each of 25 minutes. There will be a pre-test poll before the talk and a post-test poll afterwards. At the end of the talk, we will have the question and answer session. You're all requested to type your questions during the session in the chat box, and they will be answered by the experts. And if you want to personally ask the question, you may raise your hand during the question and answer session. After the question and answer session, we will have the comparison of the pre and post test polls. After the 2 sessions, then there will be remarks of the chairperson, and then we will conclude the session. For the first talk, I would like to invite our first presenter, Professor Dr. Bilal Muhyiddin, who needs no introduction, but briefly I will just tell. He's the professor and head of cardiology at King Edward Medical University, Amir Hospital, Lahore. He graduated from King Edward Medical College and received his initial training under Professor Hafiz Khan, and then at Punjab Institute of Cardiology. In cardiology, his areas of interest are hypertension, heart failure, and primary prevention. In intervention, his main focus is on antegrade chronic total occlusions, left main stem, and bifurcation. He is a life member of multiple local and international societies. He has published in multiple journals and has made multiple presentations and a number of conferences all around the globe, including PCR, TCT, C3, JIM, Sing Live, and such like. For his services to the profession, the Pakistan Society of Internal Medicine in 2020 awarded him the fellowship. So may I request Professor Bilal Muhyiddin to please introduce your topic, and then we will run the pre-test poll.
Assalamu alaikum. Can you see my slides?
Yes, sir, we can see your slides.
Okay. So briefly, it's about hypertension, and a lot of things have been discussed. I'll try and touch something different today. And I think as I'll go on, you'll have the whole idea coming up. And please start the pre-test.
Can we have the pre-test poll?
We are done with the poll.
Okay, thank you. So it seems I've got a little bit of a work set out. Can you all hear me well?
Yes, we can.
Perfect.
Yes,
Thank
we
you,
can,
sir.
sir.
Okay, so to start off, this is my first slide. Basically, this was to make you wake up and say that, look, we are all roasters at the end of the day, and everyone has got a presentation, and we have to go through it, but you must try and understand what the whole discussion is about. There are no specific disclosures for me, but look at this BP apparatus that we have been using for 100 years plus now. This is where the big disclosures actually lie. If you look at this BP apparatus, one thing is that over here, there should have been a lever, which many of them now carry, which is basically to help you equate and make sure that the mercury is down. Because if your mercury is hanging somewhere over here, and then there's an air column, and you feel that no, then you're not going to get your right readings. So you must always be very careful with your instrument. Again, this cuff that you have must have a good tight fitting, and it must cover 3/4 of your arm circumference as far as the bladder is concerned, and as far as the rest is concerned, it must be a tight fit. You should never ever ask your patient to hold this thing and apply pressure as you are taking the BP, because then you are going to cause an artificial increase in the blood pressure, which I've seen many a times, people asking the patient to hold on to the thing because the Velcro is not holding on correctly and tight enough. So these things with these apparatuses have to be always be very well controlled. And these are also the things that keep on going on with other apparatuses. By the way, this is the French sphygmomanometer that used to be there. And look, this is not the mercury one. This is the Android one. They had started coming up with these even at that time. And you know that hypertension as a medical entity really came into being in 1896 with the invention of the cuff-based sphygmomanometer. And this is how the whole thing started going off. I just touch a little bit of history also as we keep on going on. And this, of course, is the good old Krotokoff sounds that we are actually listening to, the hump and the thumps that are there, defined in 1905 by Nikolai Krotokoff. And then these are the ones that we keep listening, that once you have the sounds coming in and once the sounds keep on going on. And at times that muffled sounds keep on going on till the end. So the fourth sound actually becomes your diastolic sound. The term essential hypertension was coined back in 1911, and it described as when no cause was known. And then in 1928, they found out the malignant hypertension when strokes and heart failure and kidney used to hit. Failure was there, and people would normally succumb to the disease within a year. Consequently, hypertension has been classified into malignant and benign, but this is not as simple as that, of course. Again, another BP cuff apparatus that we normally come across using, and the same issues with this one. How you are going to do, and the lever actually keeps moving away from the heart midline levels, and then if you try and put that one on, so you have to make sure that your cuff is one which is very well secured and your dial is at the level of the heart. In 1931, John Hay, professor of medicine in Liverpool University, wrote this: "There is some truth in the saying that the greater danger to a man with a high blood pressure lies in its discovery, because then some fool is certain to try and reduce it." Well, that was then. In 1937, as US cardiologist Paul Dudley White said, hypertension may be an important compensatory mechanism which should not be tampered with, even if we were certain that we could control it. In the Diseases of the Heart book in 1949 stated that people with mild hypertension, and at that time, keep in mind, the mild hypertension was referred to as anything between 210 and 100. And those who remember the American president at that time, he died of hypertension in the stroke later on. However, the tide of medicine has been changed, and since 1915s, a lot of things have happened, and especially thanks to the insurance group people who found out that this really made a difference, and then thus became the history. So, when a person has hypertension, what is his concerns? The first question, of course, is why me? The me too kind of a scenario, which actually starts coming up with all of this bloody problem. That why me? And then you have to sit down and you start talking about genetics, that this is the way you were born, that's what your parents had. And then a lot of other questions have to be answered. But one thing that we have to always assess and tell the patient is that it is your lifestyle which may be at the mistake. How you sit, how you work, what kind of a food are you having? Is it salt rich? Is it well prepared? What kind of preparation materials are going in? We have to actually always give a tight concern to the patient, to his weight. If a person's weight is hitting 35 BMI, we can rest assured that he or she are going to end up in problems. So that you have to bring the BMI in the right zone. The sleep is something and the rest is something that many a times we are not giving enough attention to. And this is something that needs to be focused on, especially sleep deprivation during travel time. People start complaining that when they're traveling, the first few days they have this problem because you're not sleeping well. You're going through 18 or 20 hours of flight time, a lot of issues going on. And then your diet suddenly pattern changes, things start working. And then, of course, how you're working. If you're working away, these days many people are working from home. So there's a lot of issues because of that when you're not getting the required exercise along with it. One question that a lot of people always want to know is how frequently do I need to revisit? Last time, Professor Shabazz gave a very nice talk and we had this discussion. So I'm just going to touch it very lightly. My basic thing is depends on the reading at presentation. If more than 180, 120 and you have got target organ damage going on, the patient goes to the hospital and for the needful has to be done immediately. Between these pressures, 180, 120 and 160, 120, you don't have an organ damage going on. Yes, the need to bring that down is very quick, is as quick as possible. But keep this in mind that it takes medicine some time for it for the full effect to take place of a certain dose. It may not be within very quickly. So depending how the patient and your work requirements are, so anything between 7 to 15 days is a reasonable way of calling your patients back. 1 month, if the pressure is higher than 150/90. 2 months, if it is 140/80. 2 months, if BP is higher than 130/80 and there is some underlying chronic damage also going on, kidney disease, you have done some labs and you know things are not on the right side. 3 months, if BP is higher than 130/80 and there is no other organ involvement. 6 months, if BP is less than 130/80. And of course, well-trained self-monitoring has a place in deciding when to revisit. As has a lot of times been discussed, the ambulatory blood pressure and all of these things, they have a very important role, and a physician has to sit down with the patients and try and explain to them the need for it. Initial workup, which must be done. A urine complete must be done. Dipstick analysis are available. This dipstick is a basic thing. It has a this can easily be done even in your clinics. All you have to do is ask them to pee, put your dipstick into it. There are various types, 2, 3, 5, but you basically are looking at the fact that if he's a diabetic, how bad the diabetes are, and is he throwing out proteins, and from there you can start pushing on further investigations. Cardiac workup, since this is cardiac one, ECG must be done, and then if ECG is suggesting anything, you may have to move on towards echocardiography. If it's if it's showing hypertensive changes, look at the patient's physical analysis and then do equate it with echocardiography, because ECG analysis may be tricky. Cardiovascular analysis for the peripheral vascular disease, ankle brachial index, we had a detailed discussion on it. 0.9 cutoff is okay, and after that you start need to going on for it, especially if patient has complaints of leg aches and pains and there's no other confounding factors over there. Carotid Doppler, if you feel there is bruit going on. Renal workup always needs to be done. You must have your urea creatinine values done as early, not on an emergency basis, as early as possible. So this will help you to decide whether it is safe to give an ARB compounds, and from there, how well forward you can move forwards. Eye examination, neurological examinations, neuropathy, etc., CT scans when needed, you have to go for them. This is your basic hematological workup, if the patient has got good hemoglobin levels going on or not, if the platelet levels are good or not. Electrolytes and thyroids must always be looked at. But of course, this is something that you keep on doing as and when it is needed. Currently, since there's a lot of discussion regarding the lipid management along with it, so it would be nice to get a basic lipid analysis done at an early stage. This way you'll be able to push forward how you need to further manage it, and do you really need to start off lipid treatments early also. And in some patients, an abdominal ultrasound may also be needed. The big question always is, why manage? Where is the risk reduction maximum? The maximum risk reduction is in the strokes. You get 40% or more reduction in the strokes, while coronaries is only 20 to 25%. Please remember, that is where the big risk is. God forbid, if those who have had a family member having stroke, and the stroke leaving plenty of side issues, and they're becoming dependent. In our part of the world, at least 2 or 3 people in the family are also then caught with that patient. And this may go on for a few days only, or this may linger on for many years, and then the whole thing starts. While the coronary artery disease, normally a patient keeps on surviving himself and can do better. Regarding other organs, yes, They have to be considered as things are, but tobacco abuse is something which really needs to be pointed out along with lifestyle, and you have to sit down with the patient and explain to them what it does to you. What is my risk of MI or stroke? This is the question that always is being discussed. Risk is always dependent on the basis of next 10 years. That's how you look at it. Yes, you have the lifetime assessments also, but there's a 10-year assessment and on which you start working on. If it is less than 10%, you say it is low. At 10 to 20%, you say it is moderate. And if it is more than 20%, it is high side. Not just blood pressures, other factors have to be also be considered. It is a very difficult task. It's not something which can be done easily, but people have tried to do things. And yes, there is a primary analysis and then there is a secondary prevention also behind it. Framingham risk tool is, in my opinion, one which is quite useful. Those of you who have a paper and pencil with you, please get it and hold on to it. As I'll push on, I'll need you to write down your numbers so that you can assess what your score is. And from there, we will be able to discuss how things with Framingham scoring actually work on. Age. Look at the age. Many ways we have to look at this. Now, do notice that the age may be less. Up to this age, we have no idea. And then beyond 80, again, this does not really work. A lot of these calculators actually work after the age of 40. So these are the things that you have to do yourself. The ladies have a higher relative risk than men as far as age is concerned. So you have to sort of look at the fact, what is your age, and from there. So let us say those of us who are between the age of 50 and 54, your age risk factor is around 6. But as your age in females advances, probably because most of the men by then that time have popped off, your age starts to go up. Your risk starts to go up. As same is for smokers. Look at the fact that for females, the risk and the age smoking is higher. Only in the later age group bracket, they are equal. But rest of the period, the females actually have a higher risk score over here. Then look at the total cholesterol movements. Again, the same factor. As your cholesterols are, your risk keeps on going. Those of you who do not know your cholesterol levels, think usually this is where we are. Between 200 and 239, ladies, this is where you normally are. Keeping your score where you may be, put it down over there. For men, the same thing. If you know your score, well and good. If you don't know your score, with your age, put your score over here. And that is where you'll find yourself. Usually, unfortunately, in Pakistan, that is where we normally see our people. Now it's the HDL part. Yes, there are some studies where they have said 60. There are some which have even said out up to 55, and you may have a -1. But rest of the time, it is for both men and women, it is the same, and you have a score over here. And if those of you who do not know your score, usually it is less than 40 in Pakistan, so you have got a +2 coming up over here. Systolic hypertension. Well, systolic hypertension has these scores with it. For ladies, as your age, your pressures are there. And note, please, over here, that yes, are you taking blood pressure medications? And no, not taking blood pressure medications. So thereby saying that you're not taking blood pressure medications, your risk may be 3. But if you're taking blood pressure medications and your pressures are not controlled, you are in a far worse condition. So please note this very carefully. Same is true for men also. How you are looking after your blood pressures, you have to look at that factor over here also. So make a total over here. Whatever your score may be. And now start looking at your risks. If a man crosses a score of 12, he crosses the 10% deadly mark. And if he crosses the score of 15, he crosses the 20% mark. While in case of ladies, even at the score of 16, she is still at 4%. So that is where the risk protection, etc., are there. And then the ladies finally start to come up. If your score at 20, you cross the 10% mark, and at score of 22, 23, you start crossing over into the 20% risk mark. So you have to look at your facts, where you are. Initially, the counts looked higher for ladies, but finally, this is where you catch up. Diastolic blood pressure is always the more tricky one to have it. You need, if your diastolic blood pressure is between 105, 109, your systolics are okay. To prevent a stroke, you need to treat 333 patients, and you got a stroke prevention. If your pressures are lesser than that, but above 100, you need to look after 666 patients to prevent a stroke. And at about 1999, it's about 2,000 to a stroke. And this figure then starts to become even better. So the diastolic blood pressures have that 90 cutoff. That's why it is there. So if you want to do your risk calculations in another way, where it is done for you, go to your Google friend, type in ACC Framingham risk calculator over there, and go with this ASCED risk. Touch on it. And as you touch on it, this is what you are going to see, a risk estimation. The units of measurement, etc., are there. Now you start typing in whatever this may be. You have your age, you have your sex, etc. Normally for Pakistan, I would say you put in your others over here, and you keep on adding your story over here. Look at, put in just diabetes, it only asks yes or no. Smokers, it says current, former, never. Aspirin is there, statins are there, hypertension treatment, yes. So you have these things that you need to fill up. Now let us say, what is the risk in a 45-year-old non-diabetic with poor BP and lipids? So I've typed in these for you. At 45, male and others, systolic blood pressure is 170, diastolic is 110, cholesterol 240, HDL is at 35, LDL is at 170. He is not a diabetic. Yes, he is a smoker, on hypertensive treatment, on statins, on aspirin. So his risk factor is 20.9. This is the unfortunate place where a lot of our patients are coming up and saying that I don't have blood pressure. I don't think I have blood pressure. This is an odd phenomenon that has happened this time. So you need to sit down, show them the score, that this is where you are. You who feel that, yes, I can know my blood pressure, what it is, I know the variations, you have to sit down and explain to them, this is what happens. Keep this in mind, that if it is a lady, I've only changed sex over here. This was male, and now it is female. For females, the risk is also pretty high. It's above the 20 for men, but it is approaching for the ladies also. So you may have a sex protection, but it is not all the way over there. And in case you become a diabetic, then your risk in males, if you become a diabetic, from 20.9 jumps to 36.3. The males I've all done is from here, kept everything the same, and I've just changed to diabetic. So by becoming a diabetic, it really hits you very badly. And if you are able to control, it makes a big difference. Once BP is controlled from 170 to 120, keeping the rest of the things as before, the risk drops down from 20.9 to 15.2. He is not yet totally home, but this is where he has come in. If the BP is further managed out on hypertensive treatment, but this patient is on hypertensive treatment and this patient is not on hypertensive treatment. By treatment, we mean the drug treatment at the moment. Sorry, the risk comes down from 15.2 to 13.1. This was about other things. And if you are able to control the lipid profile of this patient, mind you, just by controlling the lipid profile of this patient, keeping the pressures at the same level, you'll be able to cut down the risk from the 15.2 and bring it below 5.4. So thus you have brought it below the 10% mark, the same person, by controlling the hypertension and by controlling the lipid profile. With controlling these two factors, you have really made a difference. And if the patient was a diabetic, unfortunately, you can't do much about it, but it is there. We hope that it will be there. So BP 140 by 90 to 120 by 80, the risk comes down further from 5.4 to 2.8. And now as he quits smoking, and for more than 6 months, his risk profile comes down to 1%. That is well below the 1.2% mark. After this, the real big question comes, what more? And what I could do was that I cut down the pressures further to 170, because we keep saying this lower is better. So this is the one question that I would like the panelists later on to discuss about, that we keep saying this lower the better, but then we keep changing our discussions also, and this calculator then takes it down to 0.6, which is half of what 1.2 is. And again, there's no need for any aspirin to come up over here. The patient is on the treatments, etc. And this cholesterol lowering has been done through exercise. But as far as the risk profiling is concerned, unfortunately, age is there. And age is an independent bad risk factor. So for this person, he gradually jumps his risk to 19.7 as the age advances. So as the age advances, your risk is going to go up. But keep this in mind, that despite the fact that the age has advanced, his risk was around 24%, but now it is 19.7%. So yes, the age will make a difference, but looking after everything will also make a big difference. The weaknesses in this scoring system have been that they do not talk about how much tobacco consumption is. It's just tobacco consumption. So you may be having 1 cigarette a day, you may be having 20 cigarettes a day or a 40. As far as this calculator is concerned, it doesn't really help you. Same is for the weight, height, and BMI corrections. 1 kg BP reduction can reduce BP by 1.6 over here. But of course, you have to first get rid of 4 kgs. The diet and salt all make a difference. You get your salts control, that will make a difference. The non-pharmacological care, of course, number 1 is the aerobic exercises that you need to do. Relaxation and meditation, we have had a big discussion on it, and especially regarding the yoga, etc. And for some people, it's the religious meditation, whichever they want to do. Alcohol is there. Now, there's a lot of discussion about it, and they say that for men, it may be 2 drinks, for ladies, it may be 1 drink. But you have to first understand what a drink or this consumption is. 1 bottle of Coke is anything between 200 to 250 ml. I really have never seen a friend of mine who is drinking and will drink only 50 ml and will say that is enough. Unfortunately, that's not the way social drinking goes, and you cannot combine these drinks either. You cannot say that I did not have the alcohol the entire week, so now I can have 14 of these. That doesn't work that way. Other diet changes did not show much benefit. The real benefit actually lies regarding the weight reduction. The diet management is all about weight. It's not about the diet. You need to get your weights down also. There are debates about this, but this is the way I look at it. As far as electrolytes, etc., they were saying, yes, now potassium salts are coming up, and there is some evidence which says that salts have really started showing some benefit, but rest of the sodium magnesium managements, they did not show any big benefit over here. How to adhere to your treatment? Proper explanation, that is the most important factor. If you do not get your patient to listen, and you do not get the patient's family to cooperate and listen, you will never be able to get the things right. And by the time then when the action comes in, it will already be too late. Simple therapies, we have always discussed that. It may be in the morning, and I'm sure we'll be hearing a lot about it from Professor Neil as the day goes on. Affordability and cost effectiveness. Those of you who have been with the course throughout, we had this direct question that if a person just can't afford the other newer medication, and you have to use a beta blocker and a diuretic because it's the cheapest possible thing in our part of the world, then that is what you have to do, because affordability and the sticking to the medication is most important. Keep a strict watch on efficacy of medicine, side effects, and these have to be done. Because if you're not going to do that, if a patient develops some rashes or something, or for has something else which is because of some other reason, they're going to blame it on it. Just like the earlier discussions that we were having in reference to the COVID business. And strengthen the system regarding the health personnel availability and safety. This has to be there. If you're traveling, there has to be an outstation travel, just as we have been trying to do this all with the COVID business. Now, this is the kind of a BP apparatus that is being recommended a lot. But for me, this is not the one. For me, it is a good, proper BP apparatus, keeping in mind the costs. This is far more expensive. And then unfortunately, these cuffs do not come in all sizes. You need to have various sizes. So this is not the kind of a BP apparatus which can be used for everyone. The cuff has to cover a certain amount of the circumference of the arm. You have preferably 3/4 of the bladder has to cover that much. And if you're not going to be doing that, you will not get the right results coming up. Yes, we should have these better things in the ICU, because especially when you are having your patients in the emergencies coming up, you need to have these, which make the life far easier for the physician over there. Professor Neil, this is especially for you. This is a book which is really followed a lot in our part of the world these days, the McLeod Clinical Examination. These are the books that are taught to the patients, to the young doctors as they come up. Look over here, that in this book, which is the latest 14th edition, it talks about the blood pressure over here in these terms, and it talks the blood pressure over here for the British Hypertension Association lifestyles in on this way. So the things do not really give a clear message to a young student. A clear message that is for a patient is that the patient should be sitting rested. Notice the way this patient in this book has been depicted as. He's lying. Notice the way the whole blood pressure system is being placed. The tubing is not being shown in the center. So these are the things which need to be shown and be demonstrated. Britain leads the hypertensive societies. Britain, and you all are doing a lot of fantastic work, but these are the basics which need to be corrected in all of the textbooks. Unless this is done, these messages will never ever go down to the young students as they are coming up, and their habits will never be there. This is a patient lying. You say the patient sitting for 10 minutes. All of these things have to be incorporated now from the very start, if we are 100% clear that this is the way it has to be done. And with that, I will say thank you, and I will end my discussion over here and move on. Thank you, sir.
Thank you, Dr. Bilal. It was a wonderful presentation. Anas, can we have the post-test poll, please?
Quite interesting results, I must say.
Okay. Now we can have the question and answers. If anybody
can we discuss the post poll?
No. We will soon show you the comparison. We will soon show the comparison, and we will ask the presenter to discuss them.
Okay.
So we can have comments from questions from the attendees. If you want to ask any questions, there were people who were raising their hands. Mr. Imran Kareem, if you're there. Dr. Zulfikar Ahmed.
Dr. Imran Kareem can unmute himself and speak up. Professor Tariq Wasim has his hand raised also.
Okay, sir. Dr. Tariq Wasim, can we have you?
Thank you. First of all, it's an excellent presentation, and what I wanted to say is that it was primarily focused on what we have been coming up with in our next course of Pakistan Hypertension, Pakistan Society of Internal Medicine, holistic approach to risk reduction. So Bilal emphasized on this, not only looking into the numbers and all that, and then the overall our goal is to reduce the risk. But this smoking and the lifestyle business, that I think probably needs to be addressed more as compared to when we are talking to the patients. So I would like to have this, what we call the patient education, and that component being addressed more as compared to the numbers and all that. That's all what I have to say.
Dr. Altaf Chima has his hand raised.
Professor Shabazz.
Actually, I just wanted to.
Thank you very much.
Just a second, Altaf sir.
I'm Dr. Chima from Lahore.
Let him.
Ji, Altaf sir.
Thank you. I want to know that Dr. Bilal has told us that reduction, for example, in stroke, if there is if there is good control of hypertension, the stroke reduction is 40%. Why not more than that? If we control all the things, hypertension, diabetes, and cholesterol, and And can we increase this risk
So as far as
from 40% more?
the initial message was basically that the hypertension, if well controlled, this is what it cuts down. As far as the rest of the factors, the diabetes, the uricemia, the exercise, etc. Yes, of course, once that is being done, that becomes in your risk profiling. But so far, these are the demographic analysis that have been demonstrated that it is the stroke where the maximum benefit actually comes in if you get your blood pressures corrected. And you have, yes, your advantages as far as the heart is concerned, very significant advantage, but the stroke has more. Shehbaz sir?
Yeah, I agree with what Dr. Bilal is saying regards the percentage. You see, when they are calculating, they actually have a trials. And then from the trial, they find out that it is a 40% reduction or a 50%. And the trials have shown that the stroke incidence is reduced by 40%. That is how they are calculated. Now, I would just like to add, as far as the score calculation is concerned, and the answer in the where there was the age limit, which was being discussed also. You see, when I put in over 60, it says this calculator does not calculate at that age. So there is definitely an age limit where you are not able to calculate the score, because once you get into the elderly age, then the calculation for the next 10 years or 20 years, I think is not possible. The second part is that as far as the mercury sphygmomanometer is concerned, the world over, it is being now discouraged because of the toxicity effect of mercury, and more of the aneroid, and even more the digital, good digital BP apparatuses are being used.
And over here, the special fact is that unfortunately today, we do not have all cuff sizes yet available in the new digital apparatuses. So these digital apparatuses, for that reason, become a tricky thing. But as far as if you get your basic, because they normally come in now 2 or 3 sizes easily. But in Pakistan, we normally have just one size normally coming up. So this becomes quite a challenge that you are not getting the right thing. Now, unfortunately, another fact actually that what I have seen is a lot of these, I've opened up these cuff apparatuses and seen what kind of a bladder they have. And the bladder actually is also quite interestingly designed. The old way of the bladder, the initial pipe used to be the center of the bladder. Now, a lot of these pipes actually are on the one side of the bladder. So that is also something which is going wrong. So there's a lot of design problems actually that have also come up. Then another problem, of course, is the fat, the conical kind of an arm. So the answer actually is that you need to have the best possible way of doing it regularly and easily, and it may come with whatever things is, but so that is why for me the answer in that thing was all that you have to have any of these apparatuses, but you have to do it in the correct and the best possible way.
Perhaps the aneroid would be the answer. The aneroid would be the answer.
I think as far as the cuff size is concerned, it is for whatever BP apparatus type you have, it will still be valid. And I just bought 2 different sizes other than the standard one for the digital apparatus also. They are now available, although
just 3 sizes are available.
Everywhere they are not available.
Yes, but for example, you see, someone wants to do a specialized job, wants to do it on the thigh. These are not available. The thigh of the mercury is only available. So we have these limitations which are there. If a person is a weight trainer and has a circumference of the arm at 28 or 29, then again it becomes a problem, because the bladder inside does not cover the 3/4 of the arm. I think Professor Neil would like to take on this challenge, that how much the bladder should be there.
Thanks, Bilal. Yeah, we are very conscious of using different size cuff, particularly for the overweight people. You get spuriously high blood pressure in overweight people if the cuff is too small relative to the arm. So a fat arm needs a big cuff. And similarly, very thin people need a smaller cuff. So we have 3 cuffs in our clinic, but your point's well made. They don't, with the machines you buy at home, and a lot of home blood pressure monitoring is taking place now, a lot of those machines only come with 1 cuff. Having said that, they've got a pretty wide range. some of them up to 42 centimeters. So it covers the vast majority of people. But I think it is important. You do get spuriously high blood pressures with a cuff that's too small.
Professor Neil Poulter, have you ever tried to measure the blood pressure from the forearm in those patients in whom you can't measure it at the level at the biceps?
No, I haven't. I suppose you put the stethoscope over the radial artery. You just put it down at the wrist. No, I haven't tried that. It's a good idea.
I do it. I do it every time. I think I find quite acceptable results.
Yeah, that is right.
They are acceptable, but you see, when you're discussing and you're teaching, you can't have acceptable. You need to be the gold standard. This is the gold standard. And you
there
have
are people
to have those
who have such big arm, even the biggest size cuff won't fit.
So that is the reason. Many a times I've actually used my thigh cuff over there, and that does the trick for me.
Our pre-test post-test comparison is now ready to be displayed.
Perfect.
Comparisons are ready.
Yes.
Bilal, you please comment on this.
I'm lucky that there were only 10% people initially in the brain side. They have shifted to 27. That's about 3 times climb as far as that is concerned. I wish it was better. I've got that target. The heart, the people who are strong believers of the heart, they are still there. The eye has totally gone away. The kidneys have come down. So I may say I've got about 50% of the job done. But the people who still believe in the heart business, they need to re-understand that it is, yes, the heart gets a lot of protection, but it is your brain which is the one which is most at a hit. And the most problem that you don't understand is that a lot of these people actually, as they are growing up in their age, they have that forgetfulness. They have got their other things of the brain that are not yet 100% known. You're only thinking of stroke. You're not thinking of all the other things that the hypertension is now being associated with the brain is. So do consider this very carefully.
Bilal, would you say that basically hypertension is a vasculopathy? And
yes,
therefore it will have an effect upon the heart, the brain, the kidneys, the eyes, everywhere. But what I feel is, and perhaps you would agree with me, that when you have a long-standing hypertension, you're going to find left ventricular hypertrophy in your patients, and that becomes a very important prognostic factor.
So that's very true, but it's I'm talking of even those young people, all those people who are those who have not developed any cardiac major ailments, but have got early signs of other problems, neurological problems coming up. Professor Neil would be good to take on this one.
Yeah, may I just interject? From an etiological point of view, causation, raised blood pressure is more closely associated with stroke than with myocardial infarction. And in terms of relative risk reduction in trials, by lowering the blood pressure by 11 or 12 millimeters systolic, you get about a 40% reduction in stroke, and you only get about a 25% reduction in coronary disease. But overall, the number of events associated with raised blood pressure, there are more coronary events prevented than stroke events because of the background underlying relative importance of coronary disease over strokes. There are more coronaries than strokes. And so if you have, even if you have the same relative effect on the heart attack and the stroke, then you would save more coronary events. And so I believe the correct answer to that is heart. The majority of events, the biggest number of events due to raised blood pressure are coronary events and not stroke. But the etiological link is stronger for stroke.
My only basically the trick question part over here was that which organ. And yes, as far as stroke and MIs are concerned, there is that data. But as far as a lot of other non-stroke etiological factors of on the brain are concerned, your early Alzheimer's coming up, your easy forgettability they're coming up, things that have still yet to be equated to. So that is where I actually took this answer to.
Let's move to the next question.
Well, over here, yes, now people are more agreeing to the fact that yes, it's the 10-year. So those who did not have the 10-year mark estimation, so they have actually understood that yes, it's a 10-year. But unfortunately, the lifetime believers are still quite high.
Next question.
Over here, it was a bit of a twisters, but yes, the scoring system is for all age brackets. Of course, as you know, it is not, and has been pointed out, and age is an independent risk factor. That is what I was trying to focus to, and nearly about 50% increase in about. Initially, there were 18 people saying agreeing with it. Now there are 32 people agreeing with it. 19% versus 30%. So there have been increasing, but the scoring system is for all age brackets. I think that is not the case. It doesn't work out that way. Regarding the last one, we have all got our own opinions. For me, it is to doing the whole thing. Mercury, as we have said, that this is something which is sort of going out, but it is still very much there. As far as the digital, of course, is unfortunately initially they said 29%, then the numbers have gone down. The all figure has slightly improved. For me, it is basically this one. So which blood pressure is being most recommended now is, of course, the digital one is being most recommended. But in our part of the world, because of our economic and availability kind of a thing, because the BP, mercury apparatus can be only about 600 to 1,000 rupees, while digital one is about 3,000 or 4,000 rupees, and is not used that frequently, etc., by the doctors. As far as the individuals themselves are concerned, I definitely agree that it's the digital one which is the better one. So, but you have to have the correct apparatus and managements, etc., to be done. This was a rather tricky thing. I did not know, but I just wanted to actually highlight this problem that we have.
Thank you so much, Professor Bilal. Wonderful presentation. With this, I think we will move on to our next talk. The next speaker is a very important speaker from UK. He's Professor Neil Poulter. He's Professor of Preventive Cardiovascular Medicine at Imperial College London, an honorary consultant physician at Hammersmith Hospital. He is co-director of the International Center for Circulatory Health, Imperial College London. He is president-elect of the ISH and on the Scientific Policy and Advocacy Committee of the WHO. In 2008, he was elected as one of the inaugural 100 NIHR senior investigators in England and Wales, and in 2009, he was elected as a fellow of the Academy of Medical Sciences. He is among the most cited academics in clinical medicine, as reported in the Thomson Reuters Highly Cited Researcher 2014 report. Professor Neil has played a senior role in the design, management, and conduct of several major trials, including ASCOT and ADVANCE. Other research activities include optimal investigation and management of essential hypertension and dyslipidemia, association between birth weight and hypertension, the cardiovascular effects of exogenous estrogen and progesterone, the prevention of type 2 diabetes, and ethnic differences in cardiovascular disease. So Professor Neil Poulter, please kindly can you just introduce your topic, and then we can run your pre-test code.
Thank you very much indeed, Dr. Kazi. It's my pleasure to have a chance to speak to this audience today, and thank you for inviting me. These are very difficult times, and my condolences to everybody involved who has lost friends, colleagues, and relatives through this dreadful pandemic. I'm looking forward very much to be able to join the audience in face-to-face, hopefully sometime in the future. However, my talk is talking about the timing, the issues of the timing of antihypertensive medication, and I'm going to discuss the evidence, the rationale, why that might be a good idea to give the tablets at night, what the evidence is, and what the current practice should be. So that's my introduction before the pre-test questions.
Thank you. So can we have the pre-test poll?
We are done with the poll.
Okay, if we finish with the poll, you're happy for me to carry on with my talk. I'm sorry we're running very late, and my apologies to everybody, but I'll try and get through this in a short order. So that's the title of my talk. I'm duty bound to give this slide. I'd like to think I don't have a conflict of interest, but the final sentence is relevant. I'm the chairman of a steering committee of a trial called the Time Trial, which does address the question of nocturnal or daytime dosing. So just an outline of my talk. I'm going to have 5 sections. First of all, why should we lower blood pressure? I think everybody appreciates that. We've just heard that from Professor Bilal, but here we go. 6 years ago, I wrote in The Lancet that raised blood pressure is the biggest contributor to the global burden of disease and to global mortality, leading to 9.4 million deaths each year. But using the latest data from Global Burden of Disease 2019, that 9.4 million has gone to 10.8 million deaths. Now that's about 30,000 deaths per day. 30,000 deaths per day, which is far greater than COVID has ever carried out and ever will do. COVID will to one extent or another disappear over the next year or two, whilst the number of deaths due to raised blood pressure will continue to increase rapidly. And that's because the world is getting older on average and the population size is getting bigger. So we're getting more and more deaths. So it's vital we learn to manage blood pressure more effectively than we currently do. This shows in low-income and low-middle-income countries where the majority of hypertension occurs around the world, subdivided into 4 regions. Top left is Latin America and the Caribbean, top right, European, Eastern Mediterranean, Sub-Saharan Africa, bottom right, and bottom left is Southeast Asia and the Western Pacific. And it shows the so-called care cascade. The setup is the same in all 4 regions, but I'll deal with the bottom left, closest to home, I guess, for you guys. The first column is 100% of hypertensives in that region. The next column, what proportion have ever had their blood pressures measured? And it's only 2/3. And then we go to what proportion had their hypertension diagnosed? Only just over 1/3. Then what proportion are treated? About 1 in 5. And then what proportion are controlled to 140/90, which is a conservative target these days. And you can see it's in single figures. So overall, around the world, the pattern's the same all throughout low-income and low-middle-income countries. And it's not a lot better in high-income countries. But the point is this, that if you look where most of the hypertension is around the world, and you get an average of those 4 regions, you finish up with single figures as a percentage of people who with hypertension who are controlled. We must improve that. So that's why we need to lower blood pressure. Why have we got poor blood pressure control? Well, I've put here a list of 7 explanations, which I think have been discussed and are mooted as being causes for this poor control. And I'm going to deal with 2 of them partly: ineffective drugs and poor compliance. Resistant hypertension is probably less than 10%. Guidelines sometimes conflict with each other, and that causes confusion, and that drives inertia. And you see at the bottom is physician inertia. Physicians are in part to blame for not using the evidence we've got and driving blood pressures to where they should go. Drug costs are an issue in different parts of the world and mean that patients can't afford to take their tablets. Side effects drive poor compliance. And I've highlighted poor compliance as one of the couple of things I want to mention. Ineffective drugs and poor compliance. And if we look at ideal drug characteristics, this comes from an excellent table in the ISH guidelines of 2020. We are recommended as one of the 5 ideal characteristics to use drugs that are once daily and give 24-hour blood pressure control. And that's not a new recommendation. We go back several years ago. This was a recommendation made 7 years ago from various sets of guidelines at the time. Common themes was simplify the drug regimen, use long-acting drugs, and if you can, single pill combinations, not drugs that you give twice a day or 3 times a day. We should not be using those drugs. We got to keep it simple, long-acting agents, and if you can use single pill combinations, use them. So I think it's wrong to say that we've got inactive agents. We've got 4 or 5 classes. You see them there: diuretics, RAS blockers, calcium channel blockers. They're the standard drugs which have all been shown to give good cardiovascular benefit and to lower blood pressure very effectively. So why should we give the tablets at night? What would the rationale for that be? Well, this relates to one of the questions I asked, and this shows the association between risk of cardiovascular disease on the vertical axis and systolic blood pressure, same pattern on the right-hand side for diastolic blood pressure. And for any one given level of blood pressure, you see the best predictor is nighttime blood pressure, better than 24-hour, which is better than daytime, which is better than clinic. So in terms of predicting events, the nighttime blood pressure is a better predictor than daytime, and even than 24-hour blood pressure, which I spotted was the commonest vote amongst you earlier. Just to remind you about dipping and non-dipping. Dipping is the normal thing whereby you low blood pressure at night. That's what you expect. And non-dippers means you're going to have a worse prognosis. Whatever your 24-hour blood pressure is, if you're a non-dipper, your prognosis is worse. And the absence of a normal level of dipping, and by how much you dip, that predicts mortality in patients with hypertension. Some more recent data, recently from a Japanese study, JAMP study. This looked at nighttime blood pressure phenotype and cardiovascular prognosis. And the conclusion at the bottom was, once again, that nighttime blood pressure and a riser pattern, those whose blood pressure went up at night, and some people do, they were independently associated with total cardiovascular event rate, and in particularly for heart failure. So that reaffirms what I showed you earlier. Nighttime blood pressure is a more strong predictor of adverse events. Item 4, what's the evidence to support nocturnal dosing? And I saw that many of you felt there was good evidence to support nocturnal dosing. Well, here you go. The evidence is there's some observational data from Spain, and the MAPEC group, Hamida et al. Has been prolific producing this data, observational data, not trial evidence, and Polish data suggesting that not giving the tablets at night might be better than giving the tablets during the daytime. There are some trials already in place, and there are 4 of them: HOPE, FACIT, CIS-China, and CIS-Cure, where the drugs were given at night, but they were not compared with giving the drugs at the daytime. It's just that these 4 trials gave the drugs at night, and they all gave good benefits in cardiovascular events. Everyone knows the HOPE trial. That was famous. It was a ramipril given at night. Ramipril is a relatively short-acting agent, but despite that, it got good cardiovascular events, and it's been argued that the good cardiovascular events it produces because it was given at night, and you got good blood pressure control at night, and therefore you got good cardiovascular events. Well, that might be true. Have we got comparative data of day versus night trials on cardiovascular events? This is the gold standard information we require. Have we got that? Well, there is the Hygeia trial, and you see there's a question mark next to that, and I'll explain why. I carried out a trial called the Harmony trial, which compared blood pressures given 24-hour blood pressures when you gave the tablets at the day and night, and I can show you those data. But you can see here the evidence to support nocturnal dosing is not strong, depending on your belief in the Hygeia trial. Now let me show you my trial called Harmony. And what we did is we randomized patients. These patients came from Greece and from London, our clinic in London, and the patients were randomized to receive their drugs either at daytime or nighttime, and then they crossed over. And what you can see here, and the primary endpoint was just the blood pressure, 24-hour systolic, absolutely zero difference whether you took the tablets in the morning or in the evening. So Harmony didn't support the idea that taking the tablets at night was going to give you better blood pressure control. Our conclusion was that in treated hypertensives who got stable blood pressure levels, the timing of antihypertensive drug administration, whether it be in the morning or evening, did not affect mean 24-hour ABPM. And I didn't give a chance to show it, but didn't affect quality of life either. So now let's turn to the Hygeia trial. This was the trial that's caused huge amount of excitement in the press, the lay press. It's got everybody excited. It got out and everyone believing, because they've suggested that we should be giving the tablets at nighttime. And here you see the evidence. Here you see what they have come up with. Total events, total cardiovascular events, cardiovascular outcome at the top there, and then broken down a bit more: stroke, coronaries, cardiac, and minor events. And what you're seeing here is a massive reduction in everything. All the events, about a 40 to 50% reduction in all events, including non-cardiovascular death, total cardiovascular events, CVD, stroke, coronaries. You can see here, these are all huge benefits in everything in patients given their tablets at nighttime. Just to break that down further, there you are, all the different cardiovascular events you'd care about in life. The only one that wasn't statistically significant, but even that had a 23% reduction, was transient ischemic attack. These are massive reductions. Never in my 40 years in cardiovascular events, cardiovascular prevention, and looking at trials in diabetes, in lipid lowering, in aspirin, in any sort of intervention, have I seen reduction of events like this. Never, ever, ever has this been reproduced in any trial using any intervention. What's worse, or what's more surprising, is that when you look at all the subgroups, and here you are, all these subgroups down the right-hand side: sex, age, smoking, treatment, diabetes, CKD, previous events, you get consistency in all the subgroups. So every single subgroup get these massive benefits, the size of which I have never seen in cardiovascular prevention ever before. So my reaction was, when I saw this, I do not believe it. And shortly afterwards, editorials and other articles started to appear. And there you see a group of pretty heavy duty hypertension world specialists, and their editorial in the Journal of Hypertension was, we should disregard the report from the Hygeia project, and that blood pressure medication should not be routinely dosed at bedtime on the basis of their evidence. Why did they say that? Well, they think and they believe that the data that was published in Hygeia was not really a proper randomized trial. Rather, it was a compilation of previously published observational data dressed up to look like a trial. This is the debate. I'm not saying it's true, that's the debate. What was remarkable was, in this trial of 19,000 patients, there was apparently no loss to follow-up. Well, for those of you who've been involved with trials, you know that isn't real. What they did report was 607 out of 19,000 were withdrawn. And once again, if you've been involved with big trials before, you'll know that's a tiny number. It's not real life. There was no apparent adjudication or audit record of the events that were or didn't happen. And as I pointed out, for the reasons I've said to you, the results look totally, totally implausible. So their bottom line of this editorial was that the reported data from the Hygeia project must be disregarded. Blood pressure medication should not necessarily be routinely dosed at bedtime. And my take is that you should give the tablets to the patients when it suits them best. When they like to take it, as long as it's a similar time every day, that's good. Because if they like the time they take it, they are more likely to take it. They will adhere to their treatment more carefully. And so that's my take. So in summary, nocturnal blood pressure is a better predictor of cardiovascular events. There are several observational bits of data suggesting that nocturnal dosing may give good cardiovascular protection. Then along came the Hygeia trial, which has produced surprising and controversial results. In progress, and this is where my disclosure was important, there is a trial of over 21,000 people who were randomized. They definitely were randomized to take their tablets at the daytime or nighttime. That trial is ongoing and will probably report at the end of this year. I can't tell you the results, but I don't know them. But when the Hygeia trial reported, we went to our Data Safety and Monitoring Committee, who look after the ethics, who are not blinded, and they looked at the data and we asked them, because of Hygeia, should we stop the trial? Because if Hygeia is correct, we have 21,000 people, half daytime, half nighttime, we are ethically bound to stop time. Our Data Safety Monitoring Committee said there was no evidence for us to stop the time trial. Now, that clearly means that if the Hygeia trial, the size of that benefit, 40 to 50% in cardiovascular outcomes, was true, we would have seen that highly statistically significantly in trial time, and we would have been told to stop the trial. We did not. So I've drawn my conclusions from that. And my final bullet is, therefore, in the meantime, we have no good data to recommend nocturnal dosing. So, should we lower nighttime blood pressure with bedtime dosing of antihypertensive agents? On the basis of the current evidence, the answer is a very clear no. Thank you for your attention.
We need to run the post-test poll now.
We are done with the polls.
Okay, we can take question answers now. Professor Bilal has raised his hand. Yes.
Assalamu alaikum once again, Professor Neil. It was when I was asking you for this presentation, I knew it's going to raise a lot of questions, etc. You see, this is exactly the thing that I was hoping that you would do, and we have got it done. On one side, we say that it's the night medication, the night time assessment is the one which really makes a difference.
No.
If you have said that.
No, I said it sorry, no, I said it predicted events.
Yes.
It is the one that makes the difference.
Yes, it did not say that it predicted the events, right?
Yeah.
So on the other hand, we don't have anything over there as far as the night medications are concerned. And the general belief or the feeling is that your best blood pressure control after medication is in your first 8 to 12 hours. After that, it sort of starts to drift back up to about loses the 20% mark, and then again comes the next dose, etc. So this becomes immediately a big challenge. Since you are not at permission to yet talk about the time trial, one really wonders this whole bit about the medication bit. One thing I would like you to talk about right now is that a lot of patients actually, unfortunately, are not on just one medication, but are on multiple medications because of diabetes or whatever. Now, in these patients who are on multiple drugs, which are then being used twice a day or thrice a day, where would you put your hypertensive medications? How would you consider that? Should we divide them out in the day because twice a day medications do show a better control of the mean? So where would you like to take it on?
Well, hang on, you started your final statement is absolutely unproven. So saying BD regimens give better blood pressure control, that's not true.
Thank you. Okay, here we go.
If you take once daily medications, for example, amlodipine, you get 24-hour blood pressure control. If you use drugs that are short-acting like Ramipril, then your point is true that after about 16 hours, the blood pressure will rise because it doesn't work. But if we're using agents, which we are encouraged to do, that give full 24-hour blood pressure control, then the evidence is giving BD regimen does not give better control. If you've got 10 milligrams of amlodipine versus 5 milligrams of amlodipine BD, you will not get better blood control with amlodipine 5 BD twice a day. Your blood pressure is just as well controlled by 10 milligrams once daily. And that's why all the guidelines have recommended it, that we use once daily agents that are long acting. Now, if we do that, all the beliefs about taking the tablets at night gives you better control at night are not withheld. That's what Harmony showed. You see, because we did this in Greece, we crossed them over from taking their tablets at night or day. Now, admittedly, because it's in our clinic, we use once daily agents, and it made no difference to the 24-hour blood pressure control. In Hygeia, there was about a 2 millimeter lower blood pressure if you took the tablets at night. There was a slight improvement in the 24-hour blood pressure, but for 2 millimeters difference, you don't expect a 40 or 50% reduction in cardiovascular events. That's science fiction. Why would you get that? So, that's the belief that Hygeia is not a proper trial, and this is hotly debated. I was interested in the post-trial feedback. It was marvelous. People saying that's shown in meta-analysis. There are no such meta-analysis, except where where Hamida has put his own observational data into meta-analysis, but they're only observational data. Trial evidence, there's only Hygeia, and it just doesn't show what, well, it shows huge benefits, but I think they're unreal, and I just find it hard to believe.
I don't know whether you, when we were doing my presentation, the last slide that actually, which I sort of demonstrated, and I don't know whether you got the chance to look at it, was basically when I was talking about the textbooks being discussed.
Yeah, I've never heard of McLeod's. I've never heard of the names on the authorship of that thing on high blood pressure, and I'm not sure it was lying. You said it was lying. It looked to me like it could have been sitting, but whatever the picture, I can't be blamed for McLeod's. The British guidelines say sitting, the International Society, all the guidelines say sitting. McLeod's, I've never heard of. And the three authors of McLeod's blood pressure thing, again, I'd never heard of them. So I can't defend that. But I'm absolutely persuaded that the British guidance is for sitting blood pressures. And that's in the British guidelines, as it is in NICE and ISH. But so not for me to defend that textbook.
Yeah, I'm not defending. I'm just saying that we all have to,
wants to say something.
Yes, sir. Oh, yeah, sorry.
Shehbaz Qureshi, you have raised your hand.
Yeah. Thank you very much, Professor Neil Poulter. It was an excellent presentation, and I quite agree with you that you do not have a randomized controlled trial to show the benefit if it is given at night, but it does improve adherence in most of the patients which we have seen. The question I wanted to ask you was, since you are actually combining a calcium channel blocker and a RAS blocker, and with a calcium channel blocker, you tend to have pedal edema. By giving it at night, have you seen that the edema is reduced? And if so, why is that?
Yes, Prof. Qureshi, yes, indeed I have. It's an anecdote. Somebody told me that taking the amlodipine at night, you got less ankle edema. First of all, let's just say, if you take your amlodipine with a RAS blocker, you definitely get reduction in ankle edema. Everybody knows that. Interestingly, you do with a diuretic as well. That shouldn't happen, but it does. But the idea of, as monotherapy, if you take calcium channel blocker at night, you get less ankle edema, was suggested to me to be the case. So I've recommended it to my patients, and it does seem to work. I mean, if you've got a huge amount, it's not going to make enough of a difference, but yeah, it does seem to work. Why? I have no idea. And can I just challenge you on your other thing? You said that nocturnal dosing improves adherence. I disagree. I don't think the evidence is for that. I think the problem is I take one tablet a day. That's a atorvastatin 20 milligrams because I'm an old male. So I take atorva first thing in the morning. When my alarm goes, the first thing it does is I take the atorvastatin. at the end of the day, people are drunk, they're tired, they've forgotten, and I don't believe they take their tablets. There's no evidence that nocturnal dosing improves adherence. I think it is to the contrary. The other argument has been that by taking short-acting diuretics, which are often used, people start peeing at night. So they don't like taking, so they don't take it at night. So I don't agree nocturnal dosing improves adherence. But anyway, your answer about CCB, yeah, I think it is better from an edema point of view if you take amlodipine at night. And why?
Yes, Dr. Taris is in the scene. You have some comments as well. So you need to unmute yourself.
Okay, thank you. Mr. Neil, most of the acute cardiovascular event occurring at around 4 a.m. or 3 a.m. And then there is a question of say nocturnal rise in blood pressure or loss of nocturnal dip. So wouldn't it be if someone is on multiple antihypertensive 2 or 3 drugs, one of the drug dosage be at that time to reduce the nocturnal say surge or some of that kind, particularly those who are on more than one antihypertensive drugs, would it not be feasible to split it into 2 dosage? First, I mean, a combination in the morning, a longer acting at probably shorter acting at night as well. What would be your take on that?
Well, that's an interesting concept because, as I said, if you're using drugs that work at least 24 hours, amlodipine is going for 36 hours. So you get no difference in your blood pressure throughout the day if you're on a long-acting agent like that. So the morning surge ceases to be affected differentially, whether you take the tablets in the morning or the evening. Now, your proposal of having good drugs, i.e. long-acting drugs in the morning, and then adding in a short-acting agent, well, if you use short-acting agent, maybe they will work that. All I can say is that there is no evidence from trials that that is the case, apart from Hygeia, and for the reasons I've said, I don't believe those results. I'm interested to see what time may support your idea that giving some of the tablets in the evening. The reason the guidelines all recommend taking the tablets once a day, doing once daily regimen, is that patients take them more effectively if you do it once a day. If you do it twice a day, you are less likely to adhere to your therapy. And so that's why, so I say to the patients, when's best for you? And if they say at nighttime, I said, okay, take them all at nighttime. Occasionally, I recommend taking nocturnal tablets when they have a side effect. Occasionally, patients say within a couple of hours of taking the tablet, I don't feel so well, but it goes away. I say, okay, well, why don't you take that tablet before you go to bed? But other than that, I try and encourage them to take them together in the morning or together in the evening, whichever suits them best. But I do use drugs that last at least 24 hours. I don't use short-acting ACE inhibition, for example.
One
more thing, responding to Professor Shabaz's comment on that when you are using the amlodipine-based therapies and taking it at night might improve the pedal edema. It might be the postural effect only that when you take amlodipine and the fluid retention has to occur, it is usually in the daytime. When you are walking, it may be more prominent, but if you take it at night time, probably since it's not that long acting, that may be lesser of edema observed. So, that can be one of the explanations, in my opinion.
Yeah, I mean, in all fairness, I haven't seen really good evidence that it does work. I've just got anecdotes from my own patients. So we're talking about a hypothesis here for why it might work. But yeah, it's interesting, isn't it? For a drug that really does work for 36 hours, why the side effect would only be peculiar, it would be improved by giving it at night. I don't get it, but whatever it is, the anecdote from my experience is that it does work.
Professor Neil, the currently the new guideline actually comes up with is that you have an ARB and you have a calcium channel blocker, most likely an amlodipine, give a slow dose and then build them on. Now, over here, and as luck would have it, a lot of the medicine that is available, it is a valsartan and amlodipine combination, which is very popularly being administered and being used. Now, one is a short acting, not as big, while the other is a long acting. Would you rather say that it should be more like a telmisartan, etc.? And what is your take on valsartan and amlodipine combination?
I don't tend to use angiotensin receptor blockers. The guidelines recommend, they vary. But if you look at most of the guidelines and look at the subgroups, whether they're diabetics, heart failure, post-MI, ACE is preferred. And indeed, the ISH guideline says that whether you choose a RAS blocker or whether you choose an ACE inhibitor or an ARB depends on the different patient types, because the evidence is not the same. And I think the evidence for ACE inhibitors is superior for ARBs, so I use ACE inhibitors. I don't use, telmisartan post-stroke didn't work. Telmisartan in the Transcend trial, where ramipril worked in HOPE, Transcend did not work using telmisartan. Okay, so I'm not persuaded that the ARBs are as good. Everyone, the elephant in the room is the cough, and I get that. There's no doubt the cough is an issue, but I don't think it's a side effect that should stop you trying the drugs, which to my mind has got the best evidence. So yeah, I think telmisartan is longer acting than valsartan. Olmesartan's been removed in several countries because of the sprue-like illness it causes. And of course, in olmesartan in diabetic patients cause an increase in cardiovascular events. So that's a separate discussion about ACE versus ARB. But yeah, if I use agents, I use the longer acting ones, but telmisartan doesn't have a very good history, does it, in terms of trials?
So I presume with ACE, you're more inclined, with ACE, I think you're more, would be more inclined towards perindopril.
I would use perindopril, yeah. Well, there are two longest acting ACE inhibitors, perindopril and trandolapril, which is why we put perindopril in the ASCOT trial. We asked the pharmacokinetics, pharmacodynamic experts, what was the longest acting ACE? And they said it was either perindopril or trandolapril. And Servier gave us perindopril. So that's why we use perindopril.
What was your take on fascinopril, which had a dual, mode of excretion? And it has sort of drifted away for some reason.
Yeah, fascinopril wasn't around when we set up ASCOT. It's a long time ago now, it's mid-90s, so it wasn't around. And I don't know the evidence on fascinopril. It's got no trials to support its use in terms of cardiovascular protection, so I don't know much about it.
Actually, fascinopril has a dual mode of excretion, and that is why it was recommended earlier on, but I think now it has lost its value and repute. Now, when we talk about telmisartan, would you agree that it has a dual mode of action? Like, for example, it has a RAS blocking effect, number one, and number two, a PPAR gamma effect, which also makes it quite attractive. Well, and then it is definitely long acting. So you are combining two long acting drugs together.
Prof. Qureshi, I'm not a basic scientist, and people argue about the methods of action, the mode of action of all these agents. I look at the trial evidence. I treat hypertension to prevent cardiovascular events, and I look at telmisartan trials, and I'm disappointed. Where progress worked post-stroke, Profess failed. Drug used, telmisartan. Where HOPE worked in high-risk patients with ramipril, Transcend failed. Drug used, telmisartan. So this is the other argument is, okay, well, what about on target, where this compared the ACE with an ARB, and you got equivalent cardiovascular events, but you didn't get equivalent blood pressure lowering. The telmisartan at night lowered systolics 4 millimeters more than the ramipril. And the result of that is that you, despite that 4 millimeters at night, which should predict better cardiovascular events, there was the same blood pressure lowering. So for blood pressure equivalence, I think the ACEs are superior than ARB. But we've gone off the topic, really.
One thing over here is that I'd like you to talk about is that when you have got your four drugs failure, and the patient has been on them for 6 months plus, how frequently do you ask for renal artery ablations? And what is your experience with that?
Renal denervation.
Yeah.
Yeah, well, very rarely now. There was a time where I would do that, but with 4 drugs, I mean, I would have, depending on you're going to be on an ACE inhibitor, a calcium channel blocker, a thiazide-like diuretic. I would add in doxazosin 4. 5th line would be spironolactone. If after spironolactone I still haven't got control and the patient is taking their tablets, which you need to check very carefully. But if after those 5, I think there then is the opportunity to consider renal denervation. Some people would add in a beta blocker at that stage before they're doing it, and I think I probably would. I would add in a beta blocker as my 6th line agent, and then I would go to renal denervation. And now that they're getting better devices, and I think you need an experienced person who's done it a lot, and they've got these new devices which are giving better burns. They're working more effectively on the, but the evidence, I think on average, you are getting a little bit of benefit.
So we're running short of time now. We have the results of the poll comparison. Can you please comment on the results now?
Yep. Yeah, COVID is nothing like as big. It's never, ever been 30,000 a day. It is raised blood pressure by a long, long way. The answer is it's the mean nighttime systolic pressure. I'm afraid those who stopped with the mean 24-hour is wrong. The mean nighttime systolic blood pressure is the best predictor of cardiovascular events. Surprising, but true. The evidence to promote this, there is no evidence of meta-analysis of trials of the benefits of nocturnal dosing. I think the evidence is between equivocal. I think we've got, what we do have is one trial. So we've got Hygeia, and I think many people don't believe the results. So I would put it as one of the last 2. It's almost non-existent in my opinion, and equivocal at best, but certainly not demonstrated by meta-analyses. So 39% of you, I disagree. Well, as I said it, I think this is the story about you should give the drugs when it suits the patient best. So mine was the 3rd choice here, where I've said that if it suits you to take it best at night, it means you're going to adhere. If you adhere, your blood pressure is going to be lower. That's what we want. So I would have gone for the 3rd choice. If it suits the patient's best, adherence is optimized. But the early morning rise in blood pressure isn't attenuated anymore if you take the tablets at daytime or nighttime, if they are long-acting agents, and that's what we should be using. So for those of you who voted for that, that is only dependent on using short-acting agents. Thank you.
So which agents are your favorite now? Now that's the question.
All right.
Apart from amlodipine.
All right, amlodipine calcium channel blocker. ACE inhibitor, I use perindopril. I use thiazide-like diuretic. I use indapamide, although clothalidone is longer acting, but it's more metabolically unfriendly. So I use indapamide because of its, and in Pakistan with so much diabetes, that's what I would go for. I use doxazosin GITS in its, so it's slow release formulation of doxazosin if I need that. And I use spironolactone, which is a long-acting agent. So there are my 5 drugs. If I am forced into using a beta blocker, which I don't much, I tend to use bisoprolol because it's a longer-acting agent.
Thank you so much, Professor Neil. It was a wonderful experience having you in our session. Now I would like to invite our chairperson, Professor Mohammad Ishaq, for the concluding remarks.
Professor Ishaq, you need to unmute yourself. Professor Ishaq, you need to unmute yourself. And the Pakistan Hypertension League and Pakistan Cardiac Society also support this program.
Assalamu alaikum. And first of all, I would like to congratulate the organizers and the office bearers of PSIM and their supporters for having this very important academic activity. And thanks to them for inviting me as the chairperson. It's a great honor for me. And yes, it is a combined effort of PHL and PSIM. And I hope this collaboration will continue in the best interest of our patients and profession. I came to know at the end of the discussion that I was allowed to interrupt in between. I thought I should keep my comments towards the end. I had a couple of questions in my mind, but most of them were discussed by Shabaz and Bilal and others very successfully. Hypertension is a very vast subject, and I think we are learning every day more and more about hypertension, how to control it, how best to control it. But there are quite a few things that as a professionals, we need to know, understand, and realize. The one thing is that Professor Bilal has pointed out about patient education. I think this is an extremely important point. Unless we educate the patient, we cannot improve the compliance. So the patient education about the adverse effects of hypertension and the benefits of lowering it and the lifestyle modification are extremely important in our approach to reduce the burden of hypertension in the community. Regarding the test and basic workup, I would like to divide the workup into basic workup, which must be done to every patient because it's such an enormously prevalent disease. 25–30% people suffering from hypertension. And most of the GPs, they see the patients. It's very difficult for them to undertake all sorts of investigations. So therefore, we have to simplify the battery of tests. So basic investigations will include a urine analysis and hemoglobin A1C, because diabetes is the most common association with hypertension. And as Professor Porter has pointed out, it is growing very fast in our part of the world. And then comes advanced tests. Advanced tests can only be undertaken if you are thinking of resistant hypertension, any question of secondary hypertension, comorbids. Then, of course, you need to proceed for ECG and other sophisticated investigations. But because hypertension is so widely prevalent, I think we have to minimize the investigations and be very focused. The other point was about the hypertension equipment, blood pressure measuring equipment. Whereas equipment is very important, the methodology is equally more important. Unless we have a clear-cut concept of how best to take the blood pressure measurement, whatever instrument we use, we may not get the proper reading. So I think very important is that we should have a proper methodology. And as pointed out by Dr. Bilal, some books may have a misleading pictures. I think the sitting position and the AHA, ACC guidelines about blood pressure measurement are extremely important. And the other thing is that ambulatory blood pressure monitoring is very much underutilized in our country. And I think whenever we are in doubt, we have already known that office blood pressure is not the true indicator of blood pressure level. It is the home blood pressure which determines your risk for cardiovascular events, or it gives you a proper diagnosis. So I think more and more ambulatory blood pressure monitoring should be used in our patients where we have doubt about the diagnosis, and we should make it clear that we are dealing with a definite hypertensive patient rather than a doubtful hypertensive patients. The guideline confusion is extremely important point that has been raised in Professor Porter's presentation. I think this is the onus of the societies and the cardiologists and physicians to come up with simplified guidelines, which has to be adhered. And I think the guidelines we have produced, like PHL has produced 3 guidelines, ISH guidelines, ACC, European, all these add to the confusion for a general physician. So I think the best thing would be the PSIM and PHL should join hands together and create a one-page simple action guidelines. You see, what needs to be done when the patient comes to a general physician in his clinic, what 1, 2, 3, 4 things that he has to do, very simplified manner, and it should be hanging in their clinics rather than these booklets and extensive literature that is available. That's good for us, for a specialist, but for an average general physician who sees for 50 or 60 patients a day of all sorts, all variety of patients, I think it's very difficult for him to go through these details. I think he needs a simplified one-page guideline which needs to be developed. This is my own feeling after having practiced for a long time in Pakistan. The other thing is that compliance is extremely important, and that needs a proper follow-up. And in lifestyle modification, if we address aggressively 3 factors, that is salt, smoking, and sugar. These are 3 major problems that we are facing in our community at the moment. Salt intake is very high in our community. Sugar intake is very high, and we are having a lot of tobacco use plus sedentary life. So I think we have to be very aggressive with these major risk factors that are there. It's not the question of blood pressure reading. It is a question of blood pressure which has an adverse effect because this patient has got a lot of comorbids. So patient has to be taken in toto. Just taking a blood pressure and treating it by GP, I think we have to educate the GP that this patient who has got high blood pressure is also a candidate for hyperlipidemia, he's got diabetes, he's got other factors, and I think he has to be treated in total. Professor Porter has given an excellent presentation, but I think this subject is a bit controversial. If you look at the literature, there's a lot of evidence to support that meantime nocturnal blood pressure is a much better indicator of CVD events than meantime blood pressure during the daytime. And we all know about the role or significance of diurnal variation or diurnal variation of events. And we know that most of these strokes and acute myocardial infarctions, they occur early in the morning. The question is, what is night? What is the definition of night? For example, here in Europe, the night starts at 7 o'clock, but in Pakistan, night starts at midnight, after midnight. So I think there is a lot of variation in lifestyle in various communities. So we have to understand our own scenario, and we have to do some studies locally, because at least in Karachi, I know people don't sleep before midnight, and most of them, they go up to 2 in the morning and they sleep and get up midday. So I think this is very variable from community to community. But I think one way to address this question would be to identify the dippers from non-dippers. If we have a difficult to control blood pressure, patient with a lot of comorbidities and a very bad risk factor background, family history, I think we ought to have this ambulatory blood pressure monitoring to isolate people who are dippers from non-dippers. And we all know that the non-dippers have got a very high risk of cardiovascular events compared to dippers, whatever the blood pressure control may be. So I think one way of addressing this would be to differentiate between dippers and non-dippers. The literature that I have gone through, I would not be able to comment on the various trials, but at least most of the patients are taking multiple drugs. And at least if one of them is taken at night, one tablet, one antihypertensive, that increases, you see, that reduces the cardiovascular events. So if you have multiple drugs, which most of the time we are using in our patient, if one of the drug can be taken at night and the rest in the morning, I think Professor Porter might agree that it may improve.
I do not agree.
It
I
will
do
reduce
not agree.
cardiovascular.
There is no evidence for that except Hygeia, and Hygeia, nobody believes it.
Right.
No evidence for that.
Well, I stand corrected, but I think
but do you see any
because-
problem? There may not be any benefit, but do you see any problem taking medicine twice a day?
Yes, because if you take it twice a day, you don't take it. The adherence drops. As soon as you take twice-day regimens, the adherence drops. You get less good blood pressure control.
So in a diabetic patient who is taking his medication twice a day, you do not suggest that they should also, they may take their hypertensive medication.
Well, metformin BD, but you can now get long-acting metformin. It's a lot more expensive, so I'm not suggesting we should use it, but it's quite clear if you give tablets once a day, you get better adherence than twice a day, than 3 times, than 4 times. We know that. So to give BD regimens is to acknowledge you are giving inferior treatment. Now, if you have no choice, you have to do that. And that was the case with metformin. Metformin doesn't last the long day. but if we can use drugs that last 24 hours, we should do so.
Yeah, we have got EMPA now, so that does the trick.
We
for
have
us.
to let Chair conclude his remarks,
Yeah.
please.
From a practical point of view, I have, in my experience, learned that if we educate the patient and the family that the tablet should be taken first thing in the morning after breakfast, the compliance improves. Because at night, most of the time they forget, they're coming late and they're tired and they don't take medicine. See, but there are people who will be checking their blood pressure 2 or 3 times a day. And whenever they find their blood pressure is a little bit high, they would like to take another tablet. So I think it has to be individualized. It's very difficult to be you make a generalized statement that everybody should take tablets in the morning or at night. I think whereas there may not be any benefit, I don't see any harm of giving another tablet in the evening to satisfy the patient and improve the compliance. So I think there's a lot of, there's a science and there's the art of its application. I think we have to learn how to improve the compliance. In whatever way we can improve the compliance, I think the better for the patient. And Professor Poulter has touched briefly, but I think combination treatment is the most appropriate approach in reducing the burden of hypertension and improving the control. And therefore, most of the patients would like to have a single pill with 2 tablets, 2 pharmacological agents to control the blood pressure. And I think amlodipine with ACE inhibitors or ARBs in some cases makes a very good a combination that has come into practice for the last so many years. And we are all witness to the fact that it gives you a very good blood pressure control. However, the trials are open about various ARBs, whether telmisartan or candesartan. There are differences between all these. And as we get these trials reports, we learn which one is better than the other one. I think if we use the long-acting drugs, that improves compliance. And also, at the same time, we know that these patients are taking drugs for diabetes, for lipids, for antiplatelets, and so on and so forth. So we have to be extremely careful in writing these prescriptions for our patients in Pakistan, keeping in mind their economy, their lifestyle, their sleeping pattern, their dietary pattern. So there are a lot of other things which come into play other than pure science, which determines our approach to treat a certain patient population. There are a few other things that I would like to mention, but the circadian rhythm has been less understood by our general physicians, and I think we need to pay more attention to this phenomena and understand it properly. And another thing that we have come across in our practice, and we have published some papers also, is the arrhythmias associated with hypertension, especially atrial fibrillation, which is very much underestimated, understood, you see, less understood. So I think not only is left ventricular hypertrophy, but the presence of arrhythmias in the form of atrial fibrillation is another very bad indicator of cardiovascular events that must be taken into account. So I think another point was how far to go to lower the blood pressure. And again, there's a lot of controversy going on. Is the lower the better, or there is a limit where you should stop? And I think there's evidence in the literature to suggest that lowering blood pressure beyond a certain level in a particular patient may be harmful, may have more cardiovascular events. And I would like to have a comment from Professor Poulter. If you reduce your blood pressure, systolic blood pressure below 110 in some cases, if you go further down, you may have more events than if you stop at some point. So I think blood pressure science will keep on, getting more and more information and enriching us. As Bilal has pointed out, historically, there was time people thought hypertension may not be treated, should not be treated. And then came the data from the insurance companies to show that the hypertension is related with cardiovascular mortality. And now we all know that this is #1 risk factor for CVD events, especially stroke and myocardial infarction and heart failure. So I think the general physicians need to be educated more on simple guidelines, simple treatment regimes, and action plan in the form of 1, 2, 3, 4. When you see a patient, what you should do and what you should not be doing. Blood pressure apparatuses was another point discussed, and I think I will agree that digital is better than the other instruments. And we had MMM campaign for the last 4 years under Professor Porter's guidance, and the recommended apparatus was digital, Omron digital apparatus. However, it is not the apparatus, it is the methodology, and we make sure that the apparatus is properly working. Even if there is a mercury manometer, we don't mind as long as it is properly working. And we have done a little survey in Karachi, and we found that most of the clinics and hospitals, the blood pressure apparatus was non-functional. They were faulty. There was a leakage. The bulb was, you see, punctured from some point. And so I think it's very important that these apparatuses should be calibrated, should be checked from time to time, and the accurate methodology of how to best measure the blood pressure should be clearly taught to our general physicians. Unless we do that, we'll be missing so many patients and we'll be over-diagnosing so many patients. And I think with this, I would like to thank the organizers. We had excellent talk from Lal Mohyuddin as well and Professor Porter. Very nice to hear from you. You make sometimes very bold statements, which makes us, you see, think and to ponder what next and how best to clear our confusion that exists in the literature. But I think we had a very long association with Professor Porter. As a citizen of PHL and past president of PHL, I have great regard for his support to PHL. Especially we held 2 or 3 ISH 10 module courses in Pakistan with his support, and I hope his support will continue with us and with the PSIM. And Professor Aziz, congratulations for holding this very important course, and I'll always be available to you. My distinguished colleague, Professor Shabaz Qureshi, the other stalwart of our PHL, is always there, Bilal. So I think we need a lot of effort. There's a lot of scope to improve compliance, to improve control in Pakistan. There's a lot of scope. And I think there's a lot of learning going on among the general physicians also. And these courses are going to definitely add to in our campaign against the blood pressure control in Pakistan. So with this, thank you very much once again. And kind regards to all of you.
Before we sort of ask us to start checking out, Professor Neil, a question I was hoping that you would address in your talk, but you did not. And that was about the meal relation and the timing. You especially noticed that you said you take your atorvastatin first thing in the morning. A general practice over here is the statins are prescribed in the evening, and they are prescribed post-meal. So as far as the hypertensive medications are concerned, what is your take? Should they be taken on an empty stomach during meal or after meal or 2 hours after meal? Where would you put yourself?
Okay, first of all, the myth about statins being taken at night arises from simvastatin. Simvastatin should be taken at night. It's short acting. The HMG-CoA activity is mainly at night, so you need to take simvastatin at night. Atorvastatin and rosuvastatin, it doesn't matter when you take it, so you can take them in the morning, and empty stomach or otherwise, it makes no difference. The effects for the antihypertensive agents is equivocal in terms of whether you take it on a full stomach or an empty stomach. And, you know, there are slight changes. Again, whatever suits the patients. If they want to put it on their plate with their breakfast table and do it first thing, fine, so long as you take them. If they want to take it in the middle of the meal or the end of the meal, I think those differences are absolutely minimal, and we should just do whatever suits the patients best. But I'm glad you raised the statin issue. It is a myth. You should take statin at night. It is only simvastatin and the short-acting ones, maybe Prava as well, you can take at night. But Atorva and Rosuva, you can take them any time of day.
Another anecdotal thing that is happening is that the prindopril and amlodipine and indapamide combination that is available in Pakistan is called, and I presume it's also same over there, it's called XXM. Somehow the other, for me, it always sounds like XXM, and you know what that means. So with that, I'll say thank you and over to Asma.
I don't know what XXM means. I don't know what that means.
Well, you know, I'm sure you're not that old that you don't know what XXX means. But anyway, XXX with all the music, etc. But anyway.
With this, we come to the end of our webinar. It was a very enlightening session. I would like to thank our presenters, Professor Bilal Mohyuddin and Professor Neil Coulter, for the phenomenal presentations. It was a pleasure to have you on our webinar. I would also like to thank our chairperson, Professor Dr. Mohammad Ishaq, for his precious time. Thank you to all the attendees for their participation in making it possible. And thank you to the IT department for the smooth running of this webinar. And thank you to ADCO Pharmaceuticals for their endless support in this.
And this was truly an international conference. I'm sitting in USA, and the two other people are in UK, and the Aziz Saab is in Pakistan. So what an international meeting.
Dr. Qazi, may I have this opportunity to say advance Eid Mubarak to all my distinguished colleagues and the participants. Eid al-Zuha Mubarak to all of you. And we pray that COVID comes under control everywhere, so we have a free. I'm sort of stuck here because of COVID restrictions in the flights. There are hardly any flights available to Karachi these days, and the fears are horrendous. So I think let's hope that things revert to normal, and we meet often.
And hopefully we'll have Professor Neil again in Lahore or Karachi.
Inshallah.
Like we had him in
yes, by the way, PHL is holding its meeting in September in Karachi, and all of you are welcome to please attend. And if you want to submit any paper, Professor Nawaz Lashari is the convener at Civil Hospital Karachi, and you can direct to me, or Shabazz is one of the speakers, Bilal is the speaker. So I think we'll have.
Neil, you'll be happy to know that we had nearly about 210 guests on this webinar today. So your messages have gone out loud and clear.
Well, thank you all very much indeed. Can I just say a real thank you to all? I absolutely honoured and delighted to be linked with the Pakistan Hypertension Society and the Internal Medicine Group. And a huge thank you all for all your work with May Measurement Month in previous years. We've got 95 countries involved again this year. Please do it again this year. Thank you all very much for all your hard work in the past. And I hope May is any time up until the end of November in 2021 to allow for COVID working around it. So please get involved again with MMM, and thank you all very much.
And Professor Aziz Saab, I think you can take the last comment, and then we'll say goodbyes.
I think I have to fill in for Soumya. We miss Soumya today, but in the end, we always have a message for our upcoming conference. So hopefully the things would get better, although the things are a bit gloomy at the moment. But we are holding our annual conference, second annual conference in Islamabad from 30th July to 1st of August. All of you are welcome to join us, and we'll hope to see each other in person rather than on screens. And this is the message. And we also pray that this COVID situation, Shabazz is smiling, that it gets better in Islamabad. We are getting some nasty news from there that it's on the rise, but I hope that we are able to pull through and we are able to meet again. So you are all welcome to join Pakistan Society of Internal Medicine second annual conference in Islamabad at Marriott from 30th July to 1st of August. And that's the
Marriott, or is it Marriott or Serena?
It's Marriott. Serena is for some other
accommodation.
Tariq, it's going to coincide with the cardiology update in Durban.
Yes, we did talk with them, and we have a few of the delegates who would be joining both. Said they would be attending this conference and they would be coming there as well.
Yes, you'd make us drive a lot.
I wish there was a gap.
Probably not at a long time or distance to travel. So many of us
I think-
Well, with that, we'll stop this discussion, and Aziz Sahib, you can have your last comments, and
Well,
Professor
we
Neil,
have to
thank you.
conclude here because
Yes.
we have gone beyond 2, as we have promised with our attendees.
Okay, sir. I will take your permission. Thank you very much, everybody. And we hope to
Eid
see you soon.
Mubarak.
For the office.
Eid
Eid
Mubarak,
Mubarak, Professor
Ishaq.
Neil.
Eid Mubarak.
Shahbaz, Eid Mubarak.
And Neil,
Eid
your
Mubarak,
your
Ishaq.
painting and your
Thank you, Shahbaz. Thank you.
your
Thank you.
painting
Thank you
and
very
your
much. And I
big,
think to
align with
Neil
me.
Poulter also have a happy Eid.
Yes, why not?
Inshallah.
And-
Well, let's
I've
hope
got,
let's hope England wins today against Italy. You see, we have got a big event this afternoon.
Yeah, big,
Okay.
big football game.
Yeah, bit cool,
Yeah.
and Olympics are coming up.
Best
Let's
of
hope
luck for
everything
you.
is good. All the best. Take
Allah
care.
Hafiz.
All the
Allah
best.
Hafiz.
Allah Hafiz. Allah
Take care.
Hafiz. Sir, thank you
Allah
very
Hafiz.
much. Thank you, everybody.
Bye, guys.
Bye.